Title sequence. Image of the Earth rotating in outer space. Title: Disability Workforce Retention and Growth. Innovative National Strategies to Meet a Shared Global Challenge. Webinar recording, 11 December 2023. Logo of the Global Leadership Exchange.
So welcome everyone. Thank you so much for taking the time to join us today for this important webinar on disability workforce retention and growth. We're really excited to share innovative national strategies to help meet this shared global challenge. How do we attract, build the skills and keep great people in the disability workforce? And there's lots of different pieces to this puzzle that we're really excited to explore with you today. My name is Blackmore. I'm the Emerging Leaders Coordinator with the Global Leadership Exchange. You may know us by our previous name, which was the International Initiative for Disability Leadership, or the International Initiative for Mental Health Leadership. So we'll always have that caveat for a little while, but we're really excited to bring our communities more closely together and to make the acronym a little bit easier to say as well. So I'm just going to kick off with some welcome and acknowledgements, and then we'll move directly into our feature presentation from the Administration on Community Living. I'm coming to you from Australia, and part of our tradition here in Australia is, as we're a country that experienced colonisation, is to acknowledge the First Nations people wherever we're coming from. So I'm coming to you from a city that you'll know as Perth, but its much older name is Boorloo. And Boorloo is on the lands of the Whadjuk Noongar people. I was lucky enough to be born and raised here, and I love living here, and it's only as beautiful as it is thanks to the ongoing custodianship of the Whadjuk Noongar people and elders. So I want to acknowledge and celebrate their ongoing connection to land, sea, sky and story, and I extend that respect to all elders past, present and emerging, and to any First Nations people on the call or who are watching the recording back. Any First Nations people on the lands that you're on, or if you've experienced colonisation and dispossession, I acknowledge that, and I acknowledge the strength and resilience that continues to connect culture and story through time. In that similar vein of acknowledgement and respect, many of the people joining us today and many of the people who work in this space work from their own lived experience, and they work from that lived experience for the improvement of systems and the improvement of outcomes for many others. And again, it takes strength and resilience to work from that lived experience. So I want to acknowledge, honour and respect all of those who are working from their lived experience joining us today, and thank you so much for all of the work that you do. Within the Global Leadership Exchange, we are committed to thinking about how we engage with each other. We come from many different corners of the globe and many different experiences. And that means when we start our meetings, we like to kind of outline some rules of engagement, as one of our speakers very thoughtfully put it to me about a year ago now. And so I want to start by saying, all of us on this call today are brought together by shared values and a shared commitment to creating a world where everyone can thrive and belong. So as you're engaging in your discussions today, as you're bringing your great and thoughtful and provocative questions, I'd love for you to keep just 3 key things in mind. So when we're in our Global Leadership Exchange, our GLE spaces, we're inclusive of everyone. So we welcome people at all leadership stages, people of all experiences, and people of all identities. When we're having our discussions, we work from what we call the principle of charity. This is sort of a philosophical concept where we try not to read the worst possible reading, but we actually think, well, what if everyone's intentions were the best they could possibly be? Good example of this is because we're all coming from different countries, we all use different language, and the language that most people are using probably actually is best practice in their jurisdiction. For example, you might be really used to using identity first language. Other people are used to using person first. So you might hear a mix today, and that's okay. And finally, just want to really emphasize the idea of respectful dialogue. Questions and lots of different points of view are very welcome in this space, but we listen to understand. So those are our 3 kind of rules of engagement for our space together today. You'll also notice we have a few accessibility measures. So we have captioning, it's automatic captioning through Zoom available. We also have the chat turned off. So if you do use the chat, it will only come to me. That's how we'll submit questions for our discussion sessions, but that just helps everyone to have a really good experience. When we finish the event or after you leave, there is a quick survey. It takes about 30 seconds, and we build that into our practice to always keep improving events and tailor events so that they're of interest to you. So we'd love for you to take the time, and please do stick around to the end, because we have a couple of ways that you can get really actively involved and next steps just in the last 5 minutes of the webinar. So we'd love to have you for the full time. Our session today will start with a feature presentation, and I'll hand over shortly. So that feature presentation is going to explore national approaches within the United States of America to meeting the challenge of disability workforce requirements. That session will go for about an hour, and then we'll have time for about 15 minutes for questions at the end. You're very welcome. Just pop your questions in the chat as they come up, and I'll feed them back so you don't have to try and remember them. We'll then have a 5-minute comfort break. You'll see a countdown on the screen. You'll also be able to hear an alarm when that goes off. We've got too many different time zones to say a time, so we just find that countdown makes it easy for everyone. After the break, we're going to keep broadening our worldview. So we're going to hear some updates from the Republic of Ireland and from Scotland. And then we'll have an opportunity to do a discussion panel and have a bit of a round table and compare and contrast some of these great and innovative approaches. Finally, we have a bit of an update for you from the Global Leadership Exchange, and then you'll hear those great calls to action. So that's the plan for the time today. We try and give you a bit of flexibility, but as always, take good care of yourself. So if you need to jump up, take a break, don't worry, keep the Zoom open and come back when you're ready. So let me hand over now to Jennifer Johnson from the Association for Community Living. We're really thrilled to hear the presentation from the team over there. Jennifer, over to you.
Hey, Jennifer, just real quick before you start. So Aisling, apologies, but this invitation was variously sent out as starting at 11 and starting at 10. So there were several IIDL US Advisory Committee members who were hoping to come who think this is at 11. So I just notified them that it is in fact at 10. So hopefully we'll see a few more people, but if you see people coming in, it's our team who thinks that this is happening an hour from now.
Thanks, Ruby. We'll keep letting people in as they arrive. That's fine. And we are recording this session for people who'd like to watch it back. Thanks, Ruby. And Jennifer, over to you.
Great, thank you. I want to just say greetings. I'm not sure what time zone everybody is in today, but we are at 10 o'clock in the morning here in, I'm in the Washington, D.C. area. Really glad to be joining you. And again, greetings and good day to you wherever you are. I am Jennifer Johnson, and I am the Deputy Commissioner for the Administration on Disabilities, which is in the Administration for Community Living. We are part of the U.S. Department of Health and Human Services. And as Aisling said, we're going to be talking today about work we're doing to address the direct care workforce crisis that we've been experiencing for many years, but certainly got much worse during the COVID-19 pandemic. I want to share first a little bit about the Administration for Community Living. I think we've shared before about our agency, but just thought it would be helpful to provide that context as we talk to you about the work that we're doing related to the direct care workforce crisis. So as I said, the Administration for Community Living is part of the U.S. Department of Health and Human Services, which is a very large department within the American federal government. We have about 90,000 employees within the U.S. Department of Health and Human Services. And as the title says, we support various activities and services in the states related to both the health and social well-being of people who are in need of such services and supports, including people with disabilities. While we're part of a very large department, the Administration for Community Living is very small and mighty, as we like to say. We're about 200 people, so that gives you a context of our size in comparison to the rest of the workforce in the Department of Health and Human Services. We are a relatively new entity within the Department of Health and Human Services. We're a 10-year-old agency, which is somewhat unique within government. We don't frequently create new operating divisions within our departments. So again, that was a kind of rare that we were created, but we were created with the because of the need to focus on community living for both older adults and people with disabilities. There was no entity within the federal government that had that kind of focus. And so we were created around the principle that both older adults and people with disabilities have the right to live in the community. And we are really advocating for that across the federal government in all services and supports. So we have a very strong advocacy role in the federal government, which is also unique, a unique feature of ACL. We have both aging and disability programs within the Administration for Community Living. And while some of our programs do provide community-based services through community-level organizations, we also carry out work that supports research and training for supporting quality community living for both older adults and people with disabilities. As I said, we do have organizations that we support at the ground level that are providing services to older adults and people with disabilities. And those are really the kind of supports that fill in gaps in other types of services that are provided through publicly funded programs. So we aren't providing necessarily the health services that is paid for through the Department of Health and Human Services, but we are working to, again, fill in gaps where those services don't meet everybody's needs, and also working to improve the quality of those services and supports in our states and territories. In terms of our programs are doing a variety of work in a variety of areas, but certainly what we constantly hear from our grantees and from our stakeholders and people with disabilities and family members is the tremendous crisis that we have been facing with the direct care workforce shortage. And the direct care workforce to us can include people like personal care attendants, all the way up to what we call direct support professionals that are doing a variety of things to really support an individual to live in the community. As I said, we've been experiencing this crisis for many years. This is nothing new in the US. And as I said, the pandemic certainly made it a whole lot worse. We're going to share some statistics and more details around the crisis that we're facing. But certainly in recent years, particularly under the Biden administration, the federal government has been taking a more strategic and heightened approach to addressing the direct care workforce shortage. Again, both across the needs for older adults and people with disabilities, but also families of young children with and without disabilities who also are in need of care, where we're also experiencing a crisis there as well. So it's a very comprehensive approach. And within the Administration for Community Living, we, of course, have been addressing the issues related to older adults and people with disabilities. So you're going to hear today from two experts within our agency who will share not only work that we're doing within the Administration for Community Living, but also some other efforts we'll highlight that other federal agencies are doing to address this crisis. So I'll turn it over to Caroline.
Okay, thanks, Jennifer. And good morning, everyone. My name is Caroline Ryan. I am the Deputy Director of our Center for Innovation and Partnerships at ACL. and I am excited to be here and to be sharing some information about the work that we're doing. We thought it might be helpful to start the presentation with an overview of the disability and aging system of supports in the US. And so the next couple of slides will provide some background information. And I think Jennifer is going to pull up the slides here in a second. But I can just sort of give you an overview. That's sort of our first slide. Generally speaking, long-term care includes services that support health or personal care needs over an extended period of time. Most long-term care services in the US are provided at home by unpaid family caregivers and friends, and there are currently approximately 53 million family caregivers across the country. Services are also provided by paid professionals in a person's home and in the community or in institutional settings. So my part of the presentation is going to focus on the paid workforce that supports individuals with disabilities and older adults in the community. And then my colleague, Greg Link, who is also on, who works very closely with me on this issue, is also going to share information about federal efforts to support family caregivers and the interconnectedness of paid and unpaid care. So I think we'll go to the next slide. And one more. Okay, that's great. So in the United States, there isn't a single source of financing for long-term care. It includes a combination of public programs, private insurance, and out-of-pocket expenses. Medicaid is the primary payer across the nation for long-term care services, and all states, the District of Columbia, and the U.S. territories have Medicaid programs. These programs are designed to provide health coverage for people with low income. A unique aspect of the Medicaid program is that it is jointly funded by states and the federal government. States contribute between 25 to 50% of the Medicaid program, and the states set the payment rates. While the federal government establishes certain parameters for all states to follow, each state administers their Medicaid program differently, and there is variation in coverage across the country. All programs are required to cover nursing home care and some home health services, and states can choose to cover home and community-based services. And what we've seen is there's been a huge shift in the past 30 plus years from long-term care being paid for and provided mostly in nursing homes to now more care being provided in the community through home and community-based services, which is where most people want to receive care at home, and it's more affordable than nursing home care for states. So to give you a sense of size, in 2019, approximately 1.7 million Medicaid beneficiaries received care in an institutional setting, and 9.7 million Medicaid beneficiaries received home and community-based services. So while Medicaid is the primary payer of long-term care, it is not the only source of federal funding. Long-term care is included in the medical benefits package for military veterans, and the U.S. Department of Veterans Affairs administers institutional care and home and community-based care programs across the country. It's at a smaller scale than the Medicaid program, but it is a component of long-term care. And Medicare, which is a health insurance program for people 65 and older, also covers almost 9 million adults with disabilities under the age of 65, and it is completely federally funded. Medicare typically covers health services and covers shorter-term home health benefits. So there are generally two different service delivery models that Medicaid and other federal programs pay for. The first is agency-based care. That is where an agency or a business hires and schedules workers, provides training and benefits, and then bills Medicaid, Medicare, or the VA for that service provided. The other model is self-direction or consumer direction. In this model, the person receiving services has more control over who provides their care, how it's provided, and when it's provided. And currently, there are about 1.2 million Medicaid beneficiaries that are self-directing their care, and more than 6,000 veterans in the VA program. Why I'm bringing this up is self-directed programs were a really important strategy to increase the direct care workforce during the pandemic. There were concerns about COVID transmission across households, and there were also some federal flexibilities that enabled more family caregivers to be paid to provide care for beneficiaries. And a number of states are looking at extending these flexibilities now, and it is part of a larger response to the workforce shortage. So on the next slide, as Jennifer mentioned, when we use the direct care workforce, particularly for this presentation, I'm referring to a group of professionals that have a variety of different job titles, including personal care attendants, direct support professionals, direct care workers, home health aides, and other titles. These professionals may assist with hands-on personal care, activities of daily living, vocational assistance, skills development, community integration, and other tasks that support an individual's independence and quality of life in the community. The workforce is predominantly made up of women, people of color, and immigrants, and low incomes lead to high poverty rates among home care workers. 1 in 6 lives in a household below the federal poverty line. On the next slide, currently there are 4.6 million direct care professionals providing services in the community in the US, and the need is growing. This chart on the slide shows the projected population growth by age group from 2016 to 2060. And as you can tell by the yellow line at the top of the chart, the growing population of older adults continues to drive up demand for direct care workers. By 2030, 1 in 5 people in the US will be 65 and older. More than 1 million new jobs are needed by 2029 to meet the projected need, which is more new jobs than any other occupation in the US economy. On the next slide, in addition to the growing demand, this slide lists additional factors contributing to the current crisis. Now, there is a difference between a shortage, not having enough professionals, and turnover of professionals, and the US is unfortunately confronting both. The growth in working age adults is static and not keeping pace with the demand for workers. There is greater physical distance between family members, which puts more pressure on the paid workforce. It's difficult to recruit professionals due to low wages and benefits, and the state Medicaid agencies set the rates. And one of the biggest challenges facing employers is the ability to provide comparable wages to the private market. Direct care work is often a minimum wage position, and entry-level industries are currently offering less demanding work with higher wages. And so home care employers are consistently struggling to recruit and retain professionals, and annual turnover rates vary from 43 to 65%. The turnover is often attributed to lack of growth opportunities, lack of training, work environment or employer practices, poor supervision, and lack of career pathways. The next slide shows some data from 2021 and 2022. It's really a snapshot of how the shortage is impacting access to services. ANCOR is an association that represents community-based providers that support people with intellectual and developmental disabilities. And they have been conducting surveys the past few years about the impact of the workforce shortage. And what they found is displayed on this slide. Most providers stopped accepting new referrals due to insufficient staffing. Providers have ended programs and are delaying the launch of new programs due to the lack of staff. And the shortage is impacting service quality. So with all of this information, I think sort of shares, the concern that we have is that the workforce shortage is threatening access to community living. More and more people are unable to transition from institutional settings to the community because they can't find professionals to provide support at home. And people in the community who depend on the workforce to remain and thrive in the community are having trouble finding workers, receiving care, and they're at risk for institutionalization due to the workforce crisis. So on the next slide, our agency, ACL, and other federal partners, as Jennifer mentioned, have been working to strengthen the direct care workforce for years. And we wanted to share some brief information and link to some resources and trainings from our federal colleagues before providing some more detailed information about ACL efforts. So this slide shares just a few selected resources from our federal partners, including the Office of the Assistant Secretary for Planning and Evaluation. The first study looks at evidence for using assistive technology and home modifications for lifting, transferring, and repositioning to reduce home care worker injuries. The second bullet is a report that provides potential approaches to expand and strengthen the entry-level healthcare workforce. And then the third is a visualization tool that helps accompany the report in the second bullet. Our colleagues from the Center for Medicare and Medicaid Services have been working in this space for a very, very long time. And they've got some really excellent resources on how to strengthen the workforce. The first bullet is a link to online training, providing information for people who self-direct their care about how to find, hire, and retain direct service workers. The second report describes the workforce challenges in rural areas and strategies that states and partner agencies can do to improve access to high quality care. The third is a series for policymakers and stakeholders on self-direction in the direct care workforce. The fourth bullet is a report that summarizes some themes and strategies from a learning collaborative that CMS held back in 2021. And then the last link is to a set of direct care workforce competencies that really can help guide the development of education and training programs. So our last resource on this list is from our colleagues at the Department of Labor. They had a think tank, and this links to some strategies recommended by experts and a report about current policies, programs, practices, proposals, and activities related to women in the workforce. In addition to all of the resources on this slide, ACL has invested in a number of projects over the years to strengthen the workforce, and the next slide includes some links to 3 of those initiatives. So the first resource on this list, an initiative, is the Direct Support Professional Prize Challenge. This we administered a few years ago, was focused on innovative strategies to strengthen the workforce serving individuals with intellectual and developmental disabilities. And the challenge winner developed an interactive map that supports workforce matchmaking by enabling agencies to submit lists of their available staff, and then individuals can submit information about their staffing preferences, and then ideally the system helps sort of match service recipients with providers. The second initiative, ACL's Living Well grants, were awarded to 8 states, and a number of the states included workforce efforts as part of their larger focus on enhancing the quality and effectiveness of home and community-based services for people with intellectual and developmental disabilities. So activities that these states were involved in included things like establishing baseline provider data and metrics to compare across the state, and evaluating the existing direct support professional training systems, and working with self-advocates to recommend changes to the system. The third project, as a special project promoting best practices in building state capacity, this respite workers are often direct care professionals, and this special project included on the slide is from ACL's Lifespan Respite Program, which is a program in Greg's office at ACL, and it supports state and national efforts to promote access to respite for family caregivers. The respite provider training and credentialing link in the slide will connect to more information about an effort to develop, test, and scale a respite workforce recruitment training and retention program. So a lot of activities happening across ACL. And as you can tell from the last 2 slides, it's really a lot of different federal workforce initiatives have focused on improvement within a specific program, a payer, or a specific population. And our recent efforts, which are included on the next slide, are focused on bringing all of the federal investments and expertise to the table to work collaboratively to respond to the significant workforce crisis that I've described in previous slides. So one of ACL's initiatives includes collaborating with the Department of Labor and other health and human services agencies to develop the Direct Care Workforce Capacity Building Initiative. Last year, ACL awarded a 5-year grant of more than $6 million to the National Council on Aging, who with 10 partner organizations representing aging, disability, and workforce organizations are building the Direct Care Workforce Strategy Center. The goal for the Strategy Center is to serve as a hub to promote systems-level change to improve the home and community-based services direct care workforce. It is focused on curating and developing resources and best practices, providing technical assistance, supporting partnerships across aging, disability, labor agencies, and advocates, improving data collection and evaluation, and funding partnerships at the state and local level to implement strategies. We will be launching a public-facing Direct Care Workforce Strategy Center website very soon, and it will feature a resource library to support states and communities to strengthen and expand the workforce. This resource library includes workforce resources developed by agencies across the federal government. It'll be in one location for stakeholders to easily access. And the library also includes resources published by research and advocacy organizations, nonprofits and industry, and other stakeholders. The next slide shows the current focus areas the center is really laser focused on right now. The first includes identifying and curating and disseminating resources through our website library. The second is engaging in an advisory committee for the center that includes people with lived experience, including older adults, people with disabilities and family caregivers, direct care professionals, and key stakeholder groups such as service providers, entities representing state Medicaid, aging, disability, and workforce agencies, to really inform and drive the focus of the center. And then the third is facilitating partnerships and providing technical assistance to support partnerships across state aging, disability, and workforce agencies. So bringing agencies together within states with a focus on systems change to improve the recruitment and retention of the workforce. So on the next slide, ACL's work with federal partners on the direct care workforce is our center is just one of a number of efforts that are currently underway across the government to strengthen the care economy and the caregiving infrastructure, both paid and unpaid. I know my colleague Greg is going to speak to this as well in his presentation. So I'm briefly going to touch on this and talk about how it relates to the paid workforce. So earlier this year, the President of the United States directed additional federal collaboration through an executive order to increase access to high quality care and supporting caregivers. This is the most comprehensive set of executive actions that any president has ever taken to improve the care for families while supporting care workers and family caregivers. The president directed federal agencies to do what they can within their existing authorities to boost the supply of high quality early care and education and long-term care jobs, and to provide support to family caregivers. So the next slide includes a brief description of the key areas of the executive order, which collectively strive to make care more affordable for American families, support family caregivers, boost compensation, and improve job quality for care workers, and also expand care options. And we've put links into all of these slides for more information. Again, this is a high overview of a lot of the different efforts happening, but we'll make sure that everyone has a copy of these slides and access to the links if you're interested in diving into further detail on any one of these topics. So on the next slide, the executive order recognized the need for better data on the direct care workforce and tasked HHS and the Labor Department with analyzing existing data and identifying opportunities to improve data and knowledge about the workforce. ACL is part of the HHS group involved in this effort, and we are currently very engaged and moving forward with some really ambitious timelines with this work. So currently, workforce information is often unavailable or incomplete, and the data that we do have can't be broken out by states, which makes it difficult to understand the impact of state Medicaid or other policies at the state level. So this effort, the Direct Care Workforce Data Work Group, is focused on policy. What data do we need to support the workforce, meet growing demand, and improve access to high quality services? And how do we track the impacts of policy changes over time? The group is set to release its recommendations in the spring of 2024. And I did put a link to a recent blog that was published by the Health and Human Services and Department of Labor to learn more about this effort. But again, we're on a pretty quick timeline, so there'll be more information coming soon, also publicly about some of the recommendations that this group is putting forward. So I think at this time, I'd like to turn the presentation over to my colleague, Greg Link, to share some information about supporting family caregivers, the interconnectedness of the paid and unpaid caregiving infrastructure, and family caregiving activities within the Care Executive Order. I'll turn it over to Greg, and thank you very much.
Great. Thank you so much, Caroline. And thank you all for for allowing me the opportunity to talk about what I oftentimes refer to as the other side of the care coin or the care economy, and that is how we recognize and support family caregivers here in the U.S. We recognize that in order to provide an adequate array of supportive services to those people who need them, it can't be just family caregivers, nor can it be just the paid caregiving, the paid workforce. It's a both and. We have to support and recognize both and do everything that we pull using all of the levers that we have at our disposal to ensure that they have the adequate services and supports that they need. When we talk about family caregiving, if you can go to the next slide, Jennifer. When we talk about family caregiving, the concepts are a little bit different. We're talking about instances in which there's oftentimes a very close personal relationship between the person providing support and the person receiving support. We also recognize and understand that family caregivers are oftentimes thrown into their situations quite suddenly without any opportunity for preparation or any opportunity to really understand what their role may entail. And in developing the national strategy to support family caregivers, which I'm going to go into some detail in just a moment, with our partnerships with this unique public-private partnership that we had, we conducted a great deal of collected public input, did a great deal of public engagement to really understand where family caregivers are coming from, what they believe they need to see in terms of services and supports, and in some cases, major policy shifts in how we address their needs. And you can see from some of these quotes directly from family caregivers, their perceptions of the dynamic of family caregiving, their needs are different in every single situation. Some of the common themes we heard are, like the first bullet here, when you're starting the journey, you don't have enough knowledge to know what you need. Or in other words, we don't know what we don't know when we jump into a family caregiving situation. That was certainly true for me in my own situation in looking after my aging parents prior to their death. I've worked in this field for 35 years. And yet when it came to my own parents, the emotional connection and everything that goes along with it, my knowledge kind of went out the window. And so I had to really start from ground zero in building my awareness of what's available to them and really coming to terms with the fact that as a family caregiver, I needed that support. We also know that caregivers can oftentimes feel enormous senses of isolation in their role. And so oftentimes just wanting to hear from other family caregivers about what their experiences are, maintaining some social connections and being able to share what your situations are about, how you need support can be tremendously supportive. And the other thing too is education and information for family caregivers, in addition to respite, is one of the most important types of supports that we can provide them. As one caregiver told us, nobody ever taught her how to do the medical aspects of taking care of her son, and it's frightening. And so we know that we need to have better education and teaching of our family caregivers to ensure that they are more confident in their roles, and that they can truly benefit from the other services and supports that may be made available to them. And so the entire approach that we took towards developing the national strategy to support family caregivers is around how we better recognize and include and engage family caregivers throughout this entire process. Next slide. So Caroline touched a little bit earlier in her remarks on a snapshot of family caregiving in the U.S. I'm going to dive just a touch deeper into that. So it is estimated that we have nearly 53 million adults providing support to a family member or a friend. Now, that's probably a good estimate, but I would argue that it's probably an undercount. Meaning that oftentimes family caregivers are in the role and they don't recognize themselves as doing that. So if you were to ask them, are you a family caregiver? They will say something like, no, I'm a husband, I'm a son, I'm a daughter, I'm a sibling, and that's what I do. So my estimation, my guess is that 53 million adults is a huge number. It could very well be an undercount. And right now in our US Census, we don't gather that type of information about individuals and about households. We do on the grandparent kinship side of things, but not more generally in terms of family caregiving. We know that family caregivers, 24% care for more than one person, and 26% have reported that they have difficulty coordinating the care that they're doing. That certainly was my experience. We also know that of the family caregiving picture in the United States, about 2.5 million grandparents are raising grandchildren. And about 56% of these grandparents are in the younger age range of 30 to 59. So they're not typically the individuals that would typically go to an aging services organization or would necessarily look to really receive supports. They step in to raise children for a variety of reasons. Perhaps the parents are incarcerated or deployed with the military, a whole range of reasons. And one of the things we know that the kinship households that we see are formed across many different circumstances and face many different challenges. Oftentimes, these new families are formed out of very traumatic experiences. And so we have that whole undercurrent of trauma and the need to support really the emotional needs as well as the direct support needs of these families. We also know that there are unknown numbers of caregivers who are under the age of 18. We simply don't have a reliable way of estimating or even counting the number of youth that are providing services and supports to other relatives or family or friends in the United States. Next slide. Oh, next slide. So addressing the needs of family caregivers at the federal government level in the United States has been something that we've been doing since the early 90s. And through our first initial Alzheimer's disease demonstration grants to states, which provided competitive grants to states to begin to develop targeted designated services and supports for caregivers of people with dementia. That goes back to about 1992, and that program is still active under now what we call the Alzheimer's Disease Program Initiative, where we are focusing on evidence-based interventions for family caregivers of people with dementia. And those evidence-based interventions focus on helping to address the psychoeducational needs of family caregivers while providing additional direct supports such as respite, caregiver education and training, and other services and supports for caregivers of people with dementia. In 2000, Congress created the National Family Caregiver Support Program and its sister component, the Native American Caregiver Support Program, when they reauthorized the Older Americans Act that year. The National Family Caregiver Support Program and the Native American Caregiver Support Programs were really the first formal federal recognition of the importance of supporting family caregivers with a range or a package of different types of services and supports that are all meant to work together on behalf of the family caregiver and the care recipient. And those services include information to caregivers about available services and supports, assistance with navigating and accessing services and supports, so things like case management, social services, social workers, caregiver assessment all fall into that second service category. The third service category is counseling, education, and the establishment of support groups for family caregivers, recognizing that the information and training needs that are so necessary to build the confidence and maintain the confidence of a family caregiver so that they can truly understand what they're doing, know how to respond to situations, and as a result of that, hopefully benefit from some of the other softer services like respite services, which is the most predominantly used service category within the National Family Caregiver Support Program, which is the fourth category. And then the fifth service category is something we called supplemental services, which are goods and services identified by the family caregiver to be needed, that are needed to enable them to continue in their role. And oftentimes we see home modifications, legal services and supports, transportation, home delivered meals, any auxiliary service that a family caregiver identifies. And states and communities have real flexibility in determining what those services and supports can be, how they're provided. And family caregivers also have a good deal of self-direction opportunities within the National Family Caregiver Support Program. In 2010, Congress authorized and created the VA Caregiver Support Program for family caregivers of our wounded warriors and soldiers returning from various conflicts. That program is administered by the Department of Veterans Affairs. In 2006, Congress created the Lifespan Respite Care Program, which Caroline mentioned just a little bit ago. This is a competitive grant program that 39 states and the District of Columbia so far have taken advantage of to really focus on how they better improve access to and availability of respite services across the lifespan. So it's not just an aging program, it's not just a disability program, but it truly is for family caregivers, providing supports to individuals from 0 up to the very oldest old, who need assistance to remain independent in their homes and communities. We also, in 2017 and 2018, we saw the passage first of the Recognize, Assist, Include, Support, and Engage Family Caregivers Act, which I'm going to dig into in just a minute. And then very soon after that, in 2018, the passage of the the Supporting Grandparents Raising Grandchildren Act. And then finally, in 2021, with the passage of the American Rescue Plan, Congress authorized ACL to award a grant for $10 million to establish a National Technical Assistance Center on kinship and grand families, which we did, and Generations United is our grantee for that. And they are working to provide wraparound technical assistance to state and territorial government entities, tribes, local service providers on making kinship and grandparent support services more accessible and available to the kinship caregivers that they address. Next slide, please. So I mentioned that the RAISE Act was passed in January of 2018, and we view the RAISE Act as it's not a direct service program. What it's meant to do is to look across both the federal government as well as states, localities, and a variety of sectors to begin to address and understand how we support family caregivers. And really, it provides what has ultimately become this roadmap for improving supports for family caregivers across the age and disability spectrum. So the RAISE Act has 3 key components to it. The first is the establishment of a Family Caregiving Advisory Council. And the advisory council is made up of up to 15 non-federal members, so civilians from a variety of different backgrounds. So we have someone who represents the veterans, we have somebody who represents long-term care providers, the medical community, state government, family caregivers themselves, people with disabilities, and older adults who need services and supports. Right now, we have 13 non-federal members on this advisory council, and we also have representation on this advisory council from 15 different federal agencies from across the government. So a lot of representation from the Department of Health and Human Services, but we also have representation from the VA, from Social Security, from Department of Education, from the Consumer Financial Protection Bureau, a range of different federal entities that all have a role to play through the programs and initiatives that they administer. They all have a role to play in supporting family caregivers. The first thing that the Advisory Council did was develop an initial report to Congress, which they delivered in September of 2021. And that initial report to Congress dug into what the RAISE Act, what Congress said the Council needed to explore about understanding the true nature and need of family caregivers in the United States. And that's precisely what that report did. And that report laid out 26 recommendations for action for how, as a nation, we can come together to better recognize and support family caregivers. Those recommendations then form the foundation of the third component of the RAISE Act, which is the establishment and rollout of this national strategy to support family caregivers. Next slide, please. So I want to just touch a moment on the public-private partnership that emerged to really bring to life the requirements of the RAISE Act. When Congress passed the RAISE Act in 2018 and it was signed into law, it came with no appropriations, meaning that ACL was instructed to really undertake a great deal of work without additional resources in terms of funding to do so. That has since changed, fortunately, and we receive about $400,000 per year from Congress for certain aspects of our implementation activities. However, we know that that is insufficient, and so early on, after the RAISE Act was signed into law, a national foundation, the John A. Hartford Foundation, approached me about how they could be supportive of ACL's efforts in this area. The John A. Hartford Foundation was founded by the family of the A&P grocery store chain, and they have an aging focus to their work. They also have a caregiving focus to their work and the initiatives that they fund. And so they have historically funded projects of national scope, which this certainly is. And I worked with them to develop a grant to the National Academy for State Health Policy to stand up the Family Caregiver Resource and Dissemination Center. And NASHP has a few very key partners to their work that's funded by the John A. Hartford Foundation, including the National Alliance for Caregiving, which happens to be the organization that, along with AARP, does this national survey every 5 years or so that gets us that number that we say 53 million families or family caregivers are providing supports. The University of Massachusetts Boston and Community Catalyst were also key in helping us with the public outreach and information gathering that were it left up to ACL and the federal government, for us to be able to go out and survey and conduct focus groups and listening sessions would have been a very, very labor intensive, and because of the layers of approval we have to go through, would have taken us a very long time to get approval to do that. With this public-private partnership, however, we were able to expedite that process and really begin to inform the development of both the initial report to Congress as well as the national strategy. So I can't speak highly enough of this really unique partnership that we have with the John A. Hartford Foundation and NASHP and a range of their partners in this work. Next slide, please. So here's just a snapshot of the level of public engagement that through this public-private partnership, we were able to do. ACL issued in our Federal Register a request for information that was sent to the far and wide across the country, asking about caregivers to talk, asking for caregivers and other stakeholders to talk about their experiences in family caregiving, what real challenges they had, and what recommendations they had for how we can better improve services and supports to them, and how we can structure what would become the national strategy. We felt we had to have that direct input from the people that this work is meant to touch. So we got over 1,600 responses, 75% of which came from family caregivers. And it was Community Catalyst and UMass Boston that then took all of that information and analyzed it. And from there, developed focus groups and listening sessions to dig into some of the findings more deeply. And it was those listening sessions and focus groups that helped us all through 2020 and 2021. And keep in mind, we were doing a bulk of this work during the pandemic, so everything was done remotely over Zoom. It was quite an impressive piece of work, but it was these listening sessions and interviews that helped operationalize those 26 recommendations that the Family Caregiving Advisory Council articulated in their initial report. And in fact, many of the Advisory Council members sat in on these listening sessions and focus groups because it helped inform the choices that they made in the development of the strategy later on. Next slide, please. So we have a strategy now. Was ultimately developed by our two advisory councils. First, the RAISE Council, and the RAISE Act had the mandate for the development of the national strategy. We also brought in the Advisory Council to support grandparents raising grandchildren, which we established at the same time through a different piece of legislation, and they worked alongside one another. We wanted to have the breadth of the family caregiving experience reflected in the strategy. The Grandparent Council had no such mandate for development of a strategy, but they willingly and very happily joined their colleagues on the RAISE Council to focus on 5 shared goals, which we've laid out here: increase awareness and outreach, advance partnerships and engagement to make sure that family caregivers are included whenever and wherever possible and desired by the care recipient in the design of their overall supports and recognition. Goal 3 looks at how we strengthen the range of services and supports for family caregivers. Goal 4 focuses on actions and recommendations for ensuring financial and workplace security. And then goal 5 talks about and presents a range of opportunities and ideas for how we expand data research and the development and promotion of the use of evidence-based practices. So the strategy is quite comprehensive. It's not a small document. It's not a quick read, but we believe it provides a wonderful roadmap for the country. Next slide, please. And speaking of not a small document, the strategy, it's one strategy with 4 key components, and I've laid them out here. These are all active hyperlinks to each component of the strategy. The first document is an overview and a description of the strategy's goals and intended outcomes. We also provide a range of examples for potential performance metrics that states, communities, any of the sectors that are addressed by the strategy can look at to measure their progress. The second document is what we call our first principles. As the councils were developing the strategy, they recognized that there were a number of cross-cutting themes that had to be considered when implementing any of the actions, and I'm going to talk in a second about what those are. Then we have our document that lays out nearly 350 commitments or actions that our federal partners have agreed to undertake within their existing scope of authority to improve their programs and initiatives and better target them for family caregivers. And then finally, we have the section that talks about actions for states, communities, and other sectors. And that really is where all of that public input and the listening sessions help drive the development of more than 150 actions that other sectors can take to better support family caregivers. Next slide. So the cross-cutting themes that I mentioned broke out across 4 broad areas. The first, and in that cross-cut, in the first principles document, we lay out how each of these principles can be addressed with examples and how they apply, it can be applied to any action undertaken by any sector to better support family caregivers. So the first is placing the person and the family at the center of all interactions. So it's not the system focusing in on the family caregivers and the people that they're supporting have to be at the center of everything that we do. It can't be that they're responding to whatever our programs and services feel is best for them. We have to listen to them. They have to be part of the mix in every step of the way. I mentioned trauma earlier. We know that histories of trauma are prevalent in many families all across the age spectrum. And so in order for us to make sure that the services and supports that we are developing are most effective, we have to understand and speak to trauma that may be in place and can certainly affect how families and family units respond to services and supports. We also understand that race, diversity, ethnicity play a huge role in the family caregiving experience. Family caregiving is very different in different cultures. Our native cultures view family caregiving very differently from African American cultures versus our white counterparts. And so we have to understand and recognize that equity and inclusion, as well as cultural competence, is key in how we approach this work. And then finally, and here's where the connection comes in, we recognize that family caregivers, as I had said, are one side of this care economy or the care coin. And so we have to understand the implications of and address and speak to the needs of the direct care workforce as we look to improve and strengthen services and supports for family caregivers. Next slide, please. So the strategy really does promote a whole of society approach. It is a national strategy. It's not only what the federal government can do. And so the strategy has actions in here for states, tribes, community, the aging services networks, the disability services networks, community-based providers, child welfare agencies, particularly in the situation with grandparents raising grandchildren, healthcare systems and providers, businesses, and employers who every business and every employer has employees who are family caregivers. And so there's a role for business leaders and employers, communities of faith, academic institutions, family caregivers, advocates, the public. There's something in here for every sector, and I would argue that we can probably see the number of sectors increasing as we look to update the strategy later next year. Next slide, please. So the strategy is a lot of things, and it's also not a lot of things. It is really a vision and a roadmap for meaningful change, but it's not a timeline or a how-to document. It provides many examples. It also provides links to examples that have worked in some areas, but it's not going to tell every sector how to do anything. It's a baseline for action and progress, meaning that we put it out there. The advisory councils put the strategy out there, but I don't believe the word must exists anywhere in that strategy. We hope, and we have seen, that the various sectors that the strategy speaks to are hungry for this information and are hungry for the structure. And so they're coming to the strategy and using it as they begin to develop and refine and re-refine how they recognize and support family caregivers. It's a strategy for all caregiving situations and experiences. So one of the criticisms we heard early on, people would say, well, there's nothing in here about dementia, or there's nothing in here about, let's say, cancer caregivers. That's precisely the point. It's about every caregiving situation, and it becomes incumbent upon the various interest groups that support different caregiving situations to see what's in it for them. And so through our work with the National Academy for State Health Policy, we're beginning to develop these implementation guides for these various sectors to really see what's in it for them, point them to examples so that they can take up the charge and really take a role in supporting family caregivers. And finally, it's not the first, this is the first national strategy, but it's not the last. The RAISE Act is very clear. The strategy is to be updated every 2 years. We convened a new advisory council this past July. They're already beginning to work on actually tearing the whole strategy apart and looking for where we can update it and keep it current moving forward. And that's exactly what we're going to be doing. Next slide, please. So when we talk about the connection between family caregivers and the direct care workforce, we have to understand, and we need to recognize that that family caregivers can do a lot, but they can't oftentimes do it all. And so when we're talking about the connection between the direct care workers and family caregivers, we know that direct care workers are often needed to supplement and support what family caregivers do. And we also know that the availability of direct care workers can help decrease family caregiver burnout, because we have adequately staffed respite programs that can meet the respite needs, or adequately staffed and competently staffed adult day programs, or other types of supports that family caregivers can rely on to actually help meet their needs. And actually, the availability of direct care workers could enable family caregivers to provide for longer. Some of the research that ACL has done through surveying our participants in the National Family Caregiver Support Program have said that because of respite and other direct services that they receive, they've been able to provide care for the person that they're supporting longer. And so we know that there's this total connection between family caregivers and the direct care workforce. Next slide, please. So I pointed out earlier that there are resources for implementation. The RAISE Family Caregiver Resource and Dissemination Center is available to anybody. So I would encourage you all to take a look at the resources that have been developed to support implementation and uptake of the strategy. The resources that are there are constantly growing and changing. And so I encourage you to take a look. Next slide, please. I just dropped in a picture of NASHP's webpage that has developed over the course of the last 3 years. And you can take a look at their website. Next slide, please. And finally, I just wanted to touch, a little bit on where the executive order to improve care can implement or can really help to bolster what we're doing for family caregivers. What's interesting about the CARE executive order, or the CARE EO as we're calling it, is that it mentions by name the fact that our federal partners, the federal agencies that the executive order is directed at, work through the national strategy and align with what is in the national strategy to support family caregivers to improve their programs and services that they are implementing through their various authorities and initiatives. It has more than 50 different directives to federal agencies around improving and increasing access to services and supports for care workers and family caregivers. It talks about steps that federal agencies must take to improve job quality for direct care professionals. And we know that once that happens, we'll see, family caregivers will have a better set of services and supports. And then it talks about expanding availability of home and community-based services, including those funded by Medicaid and the Department of Veterans Affairs. We know that Medicaid is the largest funder of respite services, which is of direct support to family caregivers. And we know that the VA's program provides tremendous amounts of support through respite and other means to our caregivers of wounded warriors. So the CARE Executive Order is really quite exciting. And it's, I think, a wonderful validation of the importance of and the usefulness of the national strategy to support family caregivers. Next slide. That concludes my remarks. I hope that it sparks some interest, some questions. Happy to answer questions.
Wonderful. Thank you so much, Jennifer and Greg, and to Caroline as well, who I know has had to go to another appointment. So just a reminder to all of our participants, you're very welcome to share questions in the chat. If that's really not something that's going to work for you, please use the hands up function and we'll call on you. So to kick us off, we had the option to pre-submit some questions, and we received one that I'll start our discussion with. So Ruby Moore from the US asked, are you doing any targeted, concentrated work in particular jurisdictions in the US?
So can you repeat that again? Because we do, we fund many different programs that are, where the funds flow from ACL directly to states and communities. For example, the Older Americans Act, under the Older Americans Act, which is administered from out of the Administration on Aging component of ACL, which is where my office resides. Every state and territory in the United States receives a grant from ACL once a year of Older Americans Act funds that the size of the grant is based on their population age 60 and older. And then using the parameters outlined in the Older Americans Act, states and localities have the ability to design an array of services and supports for older adults and their family caregivers. And that those are called our formula grant programs. Then we have on our discretionary side, some of the competitive opportunities, such as the Alzheimer's Disease Program Initiative and the Lifespan Respite Care Program. So yes, we are working directly in states, and we are largely a grant-making entity. So does that answer your question?
Go ahead, Jen.
Mostly. Greg, thanks. First of all, Greg and Caroline and Jennifer, thanks for fantastic presentation. I've heard some version of this twice now, and now I feel like I want everybody to hear it that I know. So at least National DD Network, Independent Living Network, and Aging Network. But what I was actually wondering is, when you create such a wealth of resources and information and somewhat of a guide to say, here's what's going on at the federal government level, and you may or may not be aware of how you can apply that well. You've given some specific guidance to states around, here's some stuff you could do. And that's where I was coming from. I was wondering if any kind of forward-thinking commissioners had approached you and said, hey, could you do a little technical assistance with our IDD advisory committee or with my core management team or anything like that?
Oh, absolutely. That has happened since the strategy came out a little more than a year ago. I've been invited to speak at many different, numerous state organizations and with other stakeholder groups about how they can see their role or their place in administering parts of the strategy. I've also worked quite closely with NASHP in their development of tools and resources that speak to the many different sectors. But yes, I am more than happy to speak to any group that wishes to figure out or see what their role in the strategy is or can be. Now I'm just one me, so I can certainly do it, and I enjoy that. So hopefully, opportunities like this that have, with a recording, we can point people to the recording. And this was very general in the different presentations and work that I've done with different organizations. So for example, area agencies on aging. I will go into the strategy and pull out everything that I think is pertinent to AAAs, or get them to see how this very general thing can apply to you. You just have to look at it that way. So happy to do that.
And if I might add, and we probably should have mentioned at some point in time, in the US, and this may be similar in your countries where you are, every state and territory is different. So while we have these national strategies like Greg has outlined, each state and territory can do what they want to with it. And they all have designed their programs that are funded and supplemented through federal funds in their own way to meet their state needs. And so to Ruby's question, it's important to be able to provide information at the state and local level so people can tailor it to their needs. And I also wanted to mention that the Direct Care Workforce Center that Caroline talked about will have a website. They are working on launching that, where there will be resources available on the website that states can use and get information and tailor it again to their specific needs. And there will be work that's targeted at states to address where they need to create some strategies that will help to address the crisis. So that will be forthcoming.
Fantastic. Thank you both, Greg and Jennifer and Ruby, for such a great question. Suzanne, who is in Nova Scotia, has asked, can you speak to how you encourage buy-in by multiple partners? I know this is something, Greg, you talked about the importance of public engagement, and Caroline also talked about the deep engagement from lots of diverse stakeholders. So would you like to speak to how you develop those partnerships, build that buy-in, and keep those stakeholders on the bus?
Oh, absolutely. Like I mentioned in my presentation, the public-private partnership that emerged in our implementation of the RAISE Act is one of the most unique and exciting things that I have ever experienced in my career. I think one of the driving factors behind the willingness of many stakeholders to come to this is the universality of this issue. It starts with the members of the RAISE Family Caregiving Advisory Council, which is made of both federal employees as well as non-federal employees. To a person, every single member of that council, whether they were a federal government employee or one of the non-federal folks that were nominated, had some connection to family caregiving, whether they were currently family caregivers or had a history of it, like myself. So for everyone, it was deeply personal. We also see that this is a very nonpartisan issue, so it has tremendous support, on both sides of the aisle in Congress, which is helpful. And we also see that as you begin to talk to different groups about this, for example, I met some time ago with the Society for Human Resource Management, which is a national organization, membership organization for HR professionals, and just explained, talked to them about caregivers in the workplace, and pointed them to some data, which they were aware of, about how the experience of family caregiving can really impact the bottom line of a company or an employer. If you have somebody who's an employee that has to step out a lot, or to do those caregiving duties. So these are really universal issues, and I think that's one of the things that helps, is that it's something that pretty much everybody can relate to or associate with. the for me and how we rolled this out is that the tent is never large enough. And we welcome any partner that wants to bring some contribution to this work, whether it's information or it would be technical assistance. NASHP has their funding from the John A. Hartford Foundation. They have established a really broad network of collaborating partners through that grant. They have an advisory faculty I kind of view as almost second layer caregiving experts. We have our advisory council, and then they have their steering committee or their advisory committee for their grant. And together, we have this incredible amount of information exchange, partnership, input, review, and again, it's an issue I think that resonates with so many people that they can get on board with it.
Thank you, Greg. Building on that question from Suzanne, Tia, who's also based in the US, has asked, are there people with disabilities who are part of the new centre that you talked about and who are contributing to that important work, both from the lived experience and that expertise that they have? I know you've talked a bit about family caregivers, so we'd love to hear more about other forms of lived experience.
Yes, so on the Family Caregiving Advisory Council, we have an individual with an acquired disability, a man with paralysis who has been is a new member of the advisory council. In the previous advisory council, we had a colleague of his who represented the disability community. And in fact, both of those gentlemen have a deep connection to the direct care workforce because they rely on them to remain independent in their homes and communities. And so they bring they bring that perspective and speak to it very, very effectively. We have an older adult who receives services and supports or relies on a family caregiver. And then we have family caregivers themselves. So we have very good representation from the lived experience and the people who actually use services and supports. In NASHP's faculty, their advisory faculty to their project, they have representation from the disability organizations that represent the disability community, as well as the aging community, service providers, union, the range. So we're always looking to expand who we're bringing into this work.
Thank you, Greg. Jennifer, I might bring you in. Suzanne from Nova Scotia has asked if there's been any work done yet on the compensation levels for direct care workers. Obviously, we know the remuneration doesn't reflect the importance of the work many times, so we'd love to hear any thoughts you have to share with on compensation.
Yeah, that certainly is a significant factor in terms of the workforce crisis, and I'm sure it's true for, and I think I've heard this from some of our international colleagues, that the pay for the direct care workforce is very low, and that people can go to McDonald's or Target stores and earn more money than they can, and it's a somewhat easier job than providing the direct support. And so that certainly is a factor, and we know that many direct support professionals hold multiple jobs and oftentimes work for multiple providers so that they can earn enough money to be able to live off of their low wages. As I mentioned earlier, every state is different. And so each state is working on this in different ways. During the COVID-19 pandemic, there was some infusion of funds into the states. And so a lot of states used that additional money to increase wages for direct support professionals. And there are certainly national awareness campaigns around the importance of the workforce and the need to increase wages. I think we kind of touched upon some of the work that's going on at the federal level in terms of what the Department of Labor and how they classify direct care workers, which can help with their wages. But right now, there is no real national strategy on that and no real solution, which is again why we are addressing this issue, so that that part of the issue we can find some solutions to that, but very much something that this country is sorting through and working on, but hasn't yet figured out.
Thank you. And taking
I'll just add on to what Jennifer said. Well, it's interesting. In November, just last month, I had the opportunity to travel to Ottawa, Ontario. Canada convened their first caregiving summit. One of the things that Canada is looking to do is develop its own national strategy to support family caregivers. And throughout that 3-day conference, we approached the caregiving topic from all different angles, including the direct care workforce shortage and the crisis. And what was very interesting, oddly reassuring, is that they're having the exact same conversations that we are, the same challenges. That the need for a standard labor definition or a standard labor category for these professionals, to have meaningful wages, wages that are sufficient enough to ensure a good quality of life, and then also to address the training needs of the need for professional development, but then also some of the systemic issues, such as the racism and other types of sensitivities that we have to be aware of in order to really support these workers, to keep them in their roles and contributing the great work that they do. So it was, like I said, it was, and even about family caregiving, the conversations were all the same. Oddly reassuring. It's kind of nice to know we're all in this together. But I think it's forums like this that will help us really exchange ideas and hopefully move the ball on some things at work.
I forgot to mention one other thing, that some states, and there's a National Association for Direct Support Professionals. One of the things that they've been promoting and some states are adopting is the use of tiered certifications. And this has worked well in the childcare sector as well, to increase people's wages. But basically it's tying, compensation to the level of training people have had, or the certificates that they have. If they have certain kinds of certificates, it allows them to have increased wages and compensation. So that's been one strategy that again has been promoted and is used in some states, and helps to obviously work towards improving the quality of the workforce with the increased access to training. And I think, the fact that, because wages are so low, that's why, again, we have these issues, and also why there's such a reliance on family caregivers, and the data that Greg talked about in terms of it really falling on the shoulders of families to pick up the huge gaps that are there in terms of care for family members.
Thank you, Jennifer and Greg. One last question. We've got 1 minute left. So I'm curious to just hear, one of the things that we know creates challenges in the labour market are there are particular people who are not seen as workers, who are shut out of the labour market, but are perfectly capable and willing and would love to work. So I'm just curious if, as part of this work that you've been sharing with us, if ACL has started to explore how can we engage people who are maybe not stereotypically or traditionally seen as workers in this particular workforce, and start to unlock that amazing opportunity space.
Greg, I can start, and then if you
Sure.
want to share. One of the things that is also sort of an emerging model is peer-to-peer support. So it's individuals with disabilities supporting and providing care to individuals with disabilities. So it's kind of, while there's been peer-to-peer support around for quite a number of years, this idea of, paying your friend or peer with a disability to provide supports and sort of that interdependence that can happen between people with disabilities. Carolyn mentioned at the beginning, we did a prize competition to identify alternative ways in which states and local communities are developing solutions to the direct care workforce crisis. And one of the models that had come forward is one of the more promising ones was a peer-to-peer one, where it was people with intellectual disabilities who were receiving training so that they could become peer support models and direct support providers through this model that they were working on. So I think that definitely is an untapped workforce that we don't traditionally think about, who would obviously have a lot of expertise and understanding of the needs, and also support choice and self-determination, because that is something that they would likely understand very well. So that's just one idea that's recently emerged. I know that, Greg, you might be able to speak more to this, but I know that there's been a lot of conversation around foreign workers and immigrants who are come to this country, whether they're legal or illegal, but that, you know, is certainly viewed as a resource. And there's some states that have utilized foreign workers and immigrants as a resource for creating more of a workforce in their area, in their state. But Greg, did you have anything to add to that?
Sure. Yeah. The whole issue of immigrants or foreign workers, it's a very sensitive topic here, obviously. In the national strategy, one of the things that you'll see is that while there's a lot in there for the various sectors, you know, outside of government, the advisory council was very clear that not everything can be done, that some things simply require legislation or regulatory rules and regulatory change. So in the main document of the national strategy, the advisory council laid out, I think, 2 pages of ideas and action and things where Congress needs to act. One of those could be around, you know, a couple of things around wages, minimum wages, and also around immigration, and how do we seize the opportunity there to make some changes. Another area that we're working in is an initiative in my office called the Community Care Corps program, which we started about 5 years ago, with dedicated funding from Congress to establish a volunteer program whereby our grantee, the Oasis Institute, and their partners are making subawards to community-based agencies around the country to establish volunteer programs to support older adults and people with disabilities through non-medical volunteer type services. And so we're seeing some really great success in terms of standing up sustainable models of volunteer supports in the non-medical arena, but no less valuable. To begin to expand, you know, tap people's willingness and their desire to help and to be of use. You know, older adults who still have capacity and a desire to contribute to their communities, but they don't want to necessarily take a paid position, have opportunities here. And so we're seeing that through this Community Care Corps model.
Wonderful. Thank you both so much. We are slightly overdue for a break. So Jennifer Johnson, Greg Link, and Caroline, who unfortunately in her absence, thank you. A huge thank you from all of us for this deep dive and all of this rich input into our countries. After the break, we'll continue the theme. Greg mentioned it feels like this we're not alone in this, and we'll continue that theme when we zoom over and jump in to hear from the Republic of Ireland and from Scotland. But for now, I encourage you take a brain break and reset. We've had a lot of information. You'll see a countdown come up on the screen, and you'll hear a timer when that you'll hear an alarm when that timer finishes. So if you prefer to see or prefer to hear, then we've got you covered. But we'll see you in about 5 minutes. Thank you so much for your time and for your attention.
Huge amount of work is in collaboration with colleagues across the disability operations at the national level and across the regional levels across the HSE. So the Irish health system is structured currently across 9 community health organisations, and that is about to change in 2024 to a realignment of both the national structure and the local structures into 6 regions. So there's quite a lot of paddling going on under the surface at this stage.
Brilliant. Thank you so much for that whistle-stop tour, Brian. I'm now going to bring in Charlie, who is the Chief Executive of the Scottish Commission for Learning Disability and an amazing gentleman that I work with on a regular basis. So over to you, Charlie, to do the same, please.
Yeah, thanks, Sean. One of the things that really strikes me, and hello from Glasgow this afternoon, is the similarities. Even, Brian, as you're speaking about the amount of change that's ongoing in the earlier presentation, the amount of similarities that all countries seem to be facing. Obviously, in Scotland, we're in a unique political position with the devolved government and the Westminster government, the United Kingdom level, and then delivering through 32 local authorities and 31 health and social care partnerships. SCLD, Scottish Commission for People with Learning Disabilities, is actually a non-government organisation. We're a small independent organisation, work absolutely hand in glove with the Scottish Government in terms of learning disability policy. We're also engaged in a whole range of interconnected legislative reform that's happening, both in terms of learning disability, autism, neurodiversity, human rights, and also mental health law reform. Probably most relevant to today's discussion is the development of a national care service in Scotland, and that very much been driven by the experiences during the pandemic and the impact on certain communities, those underserved communities, as we were speaking about earlier, in terms of the pandemic, and trying to ensure a consistent approach to the delivery of health and social care. Another element really I wanted to flag was that 70% of social care in Scotland is delivered by the voluntary sector, so the independent sector, voluntary sector, not through the public sector. And that brings significant challenges. Currently at the moment, they estimate a pay differential of approximately 20% between health and social care in the public sector and health and social care in the voluntary sector. So those are some of the dynamics at play, and our role is to influence government and other stakeholders in terms of ensuring that people with learning disabilities and others are able to live their best lives possible.
That's really lovely. I'm going to bring in Jennifer now, if that's okay, just to make the panel up for the rest of the session. But I'm really fascinated actually listening to the first bit. One of the questions that's also been submitted, I think, by Suzanne in Nova Scotia, is around cultural change. How do we make this caregiving a career choice that people want to do rather than fall into? Not to say that people fall into it, but actually how do we professionalise it? How do we make it something that is felt really, really important, that it has the same resonance as we do with our lawyers and our doctors, to say actually being a caregiver is as equal? Because in some societies, particularly in our Southern European and some of our Eastern sort of South Asian communities, caregiving is seen as a really vital role within our community setting. How do we bring that ethos in, and how do we change that approach to give it a sense, and it's not purely funding related? I'm not sure who'd like to go first. Charlie, probably, I think.
Yeah, let me kick off there. Sean, absolutely. I think we make it a more attractive profession by not professionalising it, if at all possible. I think it is absolutely about getting back to the values, even the values that Aisling was speaking about at the start of our session. I can sign up to them hand on heart. And I actually think that's what we need to value in the work, are our values, what brings us to the work. I think there's a gender issue that we really need to address. I think caring, in inverted commas, in Scotland, whether paid or unpaid, is seen as women's work. And I really do think there's a huge amount of discussion to happen there. I think also that we do have to address, there's a complex interrelationship between politics, culture, and economics in terms of health and social care. And I think those are the pivot points, if you like, that we need to be having debates and discussions about. Come and work. I'm 35 years into my health and social care, social work career. I certainly saw it as an attractive option as a young person, someone who wanted to work with a value base, who wanted to be addressing injustice and social justice issues on an ongoing basis. And I think we need to get back to that. I think the job has become far too undervalued for the complexity of what we actually do. So there's some thoughts to begin with.
No, that's really, really lovely. Thank you very much for that. Brian, how are you coping with this in Ireland, particularly when you've got such a challenge around the economic position that we've just described, and also the emerging challenge around volume of people able to fulfill those roles? How are you playing that out in Ireland?
Yeah, I think, Sean, just tying into what Charlie is saying, I think there's something very special about working within disability services and within social care. And I think it's interesting that, interestingly, when you look at how we measure success, we have moved from measuring outputs to measuring outcomes. But the ultimate is to be able to measure impact. And I think ultimately, if you ask somebody who works in disabilities, it is the direct impact that is visible to them that they make to the lives of other people, and being able to support them. And that self-directedness from the perspective of the leader is critically important. An interesting change happened. 2023 was a big year of change in the Irish context, and 2024 is going to see a lot of that come through. One of the big things that happened this year is that disabilities moved out of the Department of Health and into a new department, the Department of Children, Equality, Disability, Integration and Youth. And so to have disability sit right co-equal alongside integration and equality is really critical to where we are. It was a deliberate move because it was the furtherance of the UNCRPD and moving away from that medical model of care to a social model of care. And so that sense of care brings a whole new dynamic. And we had a big session last week with the department about the development of the new strategy in Ireland. And one of the questions raised was, well, actually, should we be talking about care? Because care is really soft and is provided to other people, where under the UNCRPD and that self-directedness, we are a support, and our job is to support people with their decisions in their life, guided by them. So that I completely agree with Charlie in what he's saying. In Ireland, we have a very interesting context, and I think to go back to what Greg was saying earlier in relation to non-local workers, non-Irish workers, we could not run the Irish Health Service if it wasn't for migration and the brilliant doctors and nurses and carers that come through from other countries. One of the challenges that we've had in the retention and recruitment challenges in Ireland is actually around the registration and the professionalism of those roles. So a number of people have come through, and the process of ascertaining whether their qualification matches with an Irish qualification has really, really held up the process. So we have brilliant people ready to work, ready to go, and we just can't have their professional qualifications verified. And I think also that I would agree in that professionalizing what is instinctive for a number of people can be counterproductive. So it is that building capacity, building confidence, and letting people know that they may not have a formal third level education, but that lived experience, or as we would say, the experts by experience, is so critical to the delivery of disability services.
Thank you so much, Brian. Jennifer, I'm going to just throw another question at you, actually, not quite on this topic, but it builds on this, actually, if that's okay, I'm mindful of time. So we've talked a little bit about how systems transform together. We've seen a brilliant selection of legislative frameworks within the US, which has been developed over time to really think about how that works. And we just heard a little bit about Brian and Charlie around what they're doing there. I think it's about what next. So what would good look like in 2030, 2050 for our systems and processes to enable our communities to be really self-directed, So what does that mean for our workforce of the future? How are we moving ourselves towards that position rather than doing what we've always done and then always got what we've always got?
So that's a great question, and I think I could go in a number of directions with that. But what immediately came to mind is, what we hear so often is about, not only the recruitment, but also the retention. So to me, a future would be one where somebody doesn't have to worry about, is my person going to show up today? And is that person going to show up again tomorrow and the day after that? That they have consistency that they can rely on in terms of their support. So that is just, one simple initial thought that I have. I think tied to that, then it would be the workforce would be more recognized and valued for what they do, and therefore are also compensated for it. We figured out the financial models that are needed to compensate well, and that we're using more innovative ways to connect people. Again, Caroline mentioned this direct support professional prize competition that we did, and the prize competition winner had created a technology platform that uses a map where people can connect. So an individual with disabilities could say, I need, help getting dressed at 8 o'clock in the morning, and that's all I need. And there might be a person out there who is available at 8 o'clock and can do that. And they can connect directly. And it's all, there's quality controls in place, but they can connect in that way, and they can really self-direct their services and find somebody who can fit in where they need it. And so I think, how technology is being used in sort of that matchmaking way. I think we probably will see more of that in the future, and broader use of technology. One of the things that we've kind of focused on in this conversation is the people that are needed to provide the support to individuals in their home. And certainly because of the pandemic, we've seen an increase in a proliferation in the use and interest in the use of technology to support people to live well in their home. What we're concerned about, though, with that is that technology is sometimes seen as the solution to replace people, to the solution to the crisis. And while it can be a great innovation and a great way to support people, and they can, make their own decisions and direct themselves, we're concerned that it's a slippery slope, and that people will start using technology to replace people when people are really needed to provide the support. I do hope that there's increased use of technology, whether that's through smart homes, increased access to assistive technology and devices, or remote monitoring, that kind of stuff. But that it isn't being abused in a way that to the detriment of people with disabilities.
Brilliant. Thank you very much. I'm mindful I've got 2 minutes left before I go over time, otherwise Ashley's going to shout at me. So Charlie, 1 minute from you. What would good look like for 2030?
Well, I think very much all of what Jennifer has said. I was nodding away furiously, Jennifer. I think absolutely pay and remuneration, and that must include also pensions, because pension inequality in Scotland is driving people out of the workforce as well. Training, that valuing by society, because it always strikes me that people want the best care possible for their loved ones, but those are the people that are working in systems that don't do that and don't deliver that. So how do we make sure, and how do we make sure our society actually thinks that women's work is the best work ever? I think that's the reframe we need to do, and needs to be remunerated appropriately.
Thank you, Charlie. And Brian, finally from you, last 1 minute on the same.
Yeah, well, do you know what? I think I'm just going to, interestingly, that issue of women's work, there is a constitution for the Irish, there's we want to change the Irish constitution next year. It states that a woman belongs in the home, and talks about women's work in the home. And the constitutional amendment being proposed is to point out the value of care and the value of relationships and what makes a family relationship. And really, again, is acknowledging just the key importance of changing language to reflect what is reality. I think, Sean, if you were asked to ask me what the change would be, I think, to go back to the conversation on values, service as a value is key to what we do. I think I have an image of a kind of a dartboard or an archery board where really the bullseye needs to be the service user, needs to be the person with a disability, the disabled person. And the rings around them are the rings of support. So immediately those personal assistants or those key personnel who support them are the immediate ring around them. Behind them are the organizations and services that direct that support. And behind them, moving further out, are ourselves in terms of the health service and government departments. All of our job is to serve the ring in front of us with the ultimate ambition that there's a very clear line of sight and line of delivery from government right through to the individual, and also to capture the voice and the experience of the individual and bring that right back to government. It's much easier said than done, but I think that value of service may have been lost in this whole professionalism discussion as well, and it's key to bring it back.
Yeah, thank you so much, Brian. And can I just thank you, both Brian, Charlie and Jennifer, for a really good set of answers to the questions I posed, because you weren't prompting in advance. So for thinking on your feet, so well done for that as well. So really appreciate that. I'm just going to move in quickly just to give you a quick update around where we are around the Netherlands Leadership Exchange. The Global Leadership Exchange runs a signature event every 16 to 18 months, and in 2024 it will be taking place in the Netherlands. Our focal point will be around Utrecht, which is a little beautiful city just south of Amsterdam, very accessible for most people via transport, via trains or aircraft. So we've got our first 2 days will be based around matches. We've currently got 31 matches taking place in various places from Brussels, the UK, and around the Netherlands, 7 of which are a disability purely focused. A large number of them are mental health focused, and a number of sessions which are actually joint disability and mental health and addiction and substance use as well. So collectively, we've got a really good programme. Those matches take place on the Monday and the Tuesday of the week, the 24th and 25th of June next year. We will have a travelling day on the Wednesday, the 26th. And then we have our Leadership Exchange, which is the event on the 27th and 28th, actually in Utrecht at the Jaarbeurs Conference Centre. The topics you've listened to today will be subject to those emerging sessions that will take place as part of the matches, definitely on those first 2 days. So if you found yourself interested and want to know a little bit more, we have got the ability for you to think about the matches that we've got taking place on the Monday, Tuesday. You can sign in to connect with our organisation via gle.world, and you will see our network there to be able to see that. Our website now is very much more advanced than it was when we were IIMHL. So thank you to all of the team behind the scenes who've done that work to get us to that space. But please take a bit of time to have a look at it, to register to become a member of the Global Leadership Exchange. It is free for member countries who invest in us anyway. So most of the participants on this call today will have free membership. And if you're not, we can work something out with you, I'm sure, behind the scenes. And then ultimately, we would like you to then to think about the next steps around the match and also then towards the Leadership Exchange, so we can share and learn from your knowledge as well as the knowledge that we would hope to impart on you. Our organisation is built on developing leadership, getting that knowledge exchange, and today is just a really good example of where we've done that in a multi-supported way from across different continents. So a big thank you from me to the speakers, and I'll hand now back to Aisling, and I'm hopefully back on time.
Brilliantly done, Sean. Thank you. And thank you again to all of our speakers. So it comes to me now just to wrap up our session. So I want to say a huge thank you to all of our speakers again. You've shared your knowledge and experiences and wisdom so generously. So thank you so much, Jennifer, Carolyn, Greg, Brian, and Charlie. And thank you, my colleague Sean, for chairing. Also want to acknowledge and thank our GLE Disability Advisory Group members who helped to shape this program and who promoted it so that all of these lovely participants could attend and benefit and share their questions and comments with us as well. Our colleague Eddie Bartnik did a lot of the legwork on this and has been pulled into another meeting, so wasn't able to join us. So I want to thank and acknowledge him. And of course, attendees, thank you so much for making the time to come and join us in your busy days. We will be sharing the recording of this session and some of the resources that we've referred to within this session. That will likely be early in the new year, as we're sort of in the sprint to the festive season now. So look in your inboxes early in January. I also wanted to let you know we are in the process of creating an online library of resources on this topic specifically. It's such a key topic for every country across the globe, as you've heard today. And so I wanted to let you know how you can participate in that. So we have... we're in the process of creating this library. It will be available to members of the Global Leadership Exchange. We're asking you to submit your workforce resources. I'll put the link to this form in the chat and also my email address in case there are any issues. It's very easy. We ask you for your name, for your email, and you have the choice. Tell us what you need. We will go out and find it with all of these lovely people. Or if you have a great wealth of resources, we will add that resource to our library. If you're submitting one, we just ask that you have permission to share and just let us know where we can find those, and then we'll go categorize them. We are accepting documents, audio, videos, all kinds of formats. And this will include things like the recording from today, recordings from other similar kinds of events that we've hosted and that our member organizations, partner organizations host. So we're creating this one-stop shop for policies and implementation plans and reports and research on how we can continue this skills building and sustain that direct care or disability workforce. So we're really excited to share that opportunity with you. Finally, as I said before, we would love to see you at our Netherlands exchange. So we're absolutely excited to see everyone back face-to-face in the Netherlands in 2024. So please visit our website and register. If you're not able to join us, that's okay. Please make sure you're signed up as a member and give us feedback using the poll that will be available in your web browser at the conclusion of this event. So huge thank you again to all of you for attending. We really look forward to getting all of your great resources, any follow-up questions you have, and hopefully seeing as many of you as we can in Utrecht next year. Wishing you all a very safe and happy end to the year, however you choose to celebrate. Thank you for bringing your energy, wisdom, and experiences to share with us today. Take care, everyone.